it's a pleasure. I've been here now 15 years, but I will tell you that when I started, when I was a fellow back in 2000, what am I talking about? 1975. We didn't have anything we're talking about. Is that on? Okay. All right. Get the button. Okay. So in 1975 and 1976 at Boston, how your diabetes was treated depended on what side of Longwood Avenue you're on. So on the Joslin side, they felt tight control was really important. On the side of the Brigham Hospital, they said, well, it's not been proven, and your patients show up in our emergency room all the time, hypoglycemic. So there was no finger stick testing, there was no A1C, and there was no DCCT. So all that has changed, and this controversy for 50 years whether tight control is important was eventually resolved that it is with the DCT and the UKPDS. There's also been some controversy on inpatient, and we'll discuss that as we go along. So I have, as usual, a lot of robust learning objectives. Let me see if I can make this slide move. We're not moving here. So I have 5 learning objectives. The impact of hyperglycemia in the hospital. Thank you. There we go. Now we're cool. This consensus on inpatient glycemic targets, the components of sub-Q and IV insulin order sets, and then I want to make this talk tailored to our order set program here, and then at the end talk about iatrogenic hypoglycemia, which is a major problem. So what is the extent of the problem, and why is this important? So, and this is some data that's already 10 years old, showing that diabetes was present in 10% of discharges, affecting millions of patients and occurring in very high numbers of cardiac surgery patients, which is similar to us, about 30%, associated with longer duration, longer stay, and big cost. So if you look, we have Dr. Hardy's gotten the statistics for me, and you can see in 2011, we had actually, on discharges, 43,000, 20% with diabetes, and 80% were people without diabetes. However, if you look at insulin usage, you see it's even amazing. So here you have 32% of people on insulin, 2% IV, 30% sub-Q. So that's a significant number. So on any given day, you're talking 250 to 300 people in this hospital are taking insulin. And why is that? Well, some people, of course, have diabetes, it's known. Some have existing diabetes that was never diagnosed before. But many people have so-called stress hyperglycemia. And sometimes you're not sure. The patient, well, I never had diabetes, or I had a touch of it, or maybe I'm borderline. So it's been recommended now that patients have an A1C when they're admitted to help figure out if they are diabetic or not, and also if they were diabetic, what kind of glycemic control they've been. Many times they're supposedly taking medication, like they say they take their insulin, their A1C is 12%. So therefore, it's really important to have an idea, especially when you talk about on the other end of the spectrum, when you're sending them home, how you may want to change their regimen. Now, this is from New England Journal a couple years ago, talking about stress hyperglycemia. And basically, hyperglycemia is caused by beta cell dysfunction, insulin resistance, but it's exacerbated in the hospital situation by stress, with glucocorticoids, catecholamines, inflammatory cytokines. And then we don't necessarily help it either by giving, sometimes not feeding the people, or sometimes giving them direct glucose and so forth. So the hyperglycemia has many effects. On the cellular level, it causes mitochondrial injury, neutrophil dysfunction, endothelial dysfunction. It causes oxidant injury in the molecular effect, glycation of proteins, and complement inhibition. And then in addition, if you're hyperglycemic above the renal threshold, you have fluid depletion, hypoperfusion, electrolyte loss. And all this is set up for sepsis, impaired wound healing, and critical illness neuropathy. So this is an interesting fact about these people who are not known to be diabetic. So in this study a few years back, this study showed there were 2,000 general medicine inpatients, 26% had known diabetes, and of that group, about 3/4, 77%, were treated with insulin. Their increase in mortality is about threefold. But then they had 12% new onset hyperglycemia, but only 42% were on insulin, and they had an 18-fold increase in mortality. So I think this slide tells a lot. This is from Kinsley, published in Clinical Proceedings. So if you look at people in the hospital setting, you look at mortality, if they have normal glycemia, blood sugars, 100 or less, their incidence is about 10%. But if you look at the other end of the spectrum, you'll see it's about 42%. So basically, it's like almost a direct line going up in terms of hyperglycemia and mortality. And this is showing the same thing in this slide. New onset hyperglycemia, 16% mortality, known diabetes, 3%, and about 1.7% normal glycemia. In the ICU, normal glycemic mortality is 10%, known diabetes 11%, and new onset hyperglycemia is 31%. This was published with the Leuven data in Belgium from Taneberg. And basically, this was giving IV insulin to people who were in surgical ICUs and showed that with IV insulin as opposed to conventional sub-Q insulin, you reduce sepsis, need for dialysis, transfusion, and critical illness polyneuropathy. And we know, as mentioned, that high glucose, especially when you get over 200, causes a lot of these problems. And I'll show you that it's been known almost for 100 years why controlling glucose makes a difference in terms of infection. And here they are. So 1922, Banting and Best discovered insulin. And if you go and you Google Nobel Prize lectures, you can see the Nobel Prize speech by Banting 3 years later. And most of the data he got actually came from the Joslin Clinic. And at the time when insulin was discovered, they had many people who were presumably type 2 patients who had wounds that did not heal. So we're talking 30 years before antibiotics. So these patients were then given insulin, and the wounds such as gangrene and other infections resolved with the insulin, and then they were able to get off the insulin after it healed. So I think we have a long history of knowing that glycemic control is very important in preventing infection. And here's another slide more. This is from Fenari data in Oregon showing the inflection point. Once you get about 200, 180 to 200, it goes up. And I like this data. This is in Boston data looking at, in post-op cases, one single post-op glucose of over 220 is about a 6-fold increase in nosocomial infection. And Fenari in Portland was the first one with the heart surgery to institute IV insulin. And in fact, for many years in this hospital, we used the so-called Portland protocol. And we did, you can see the wounds. This is dehiscence, basically, and they have deep sternal wound infections, went down, and to the point where within a few years, it was diabetics and non-diabetics were the same. And that's why in this hospital, every 100% of patients who have heart surgery come out of the OR, they're on EndoTool, but if they don't need it, it's removed, rather than going the other way around and see who needs it. And the surgeons were the ones who actually have supported us, the heart surgeons, in the Portland protocol and the glucomander, and also help support us to keep the EndoTool going. Okay, so again, I think it's pretty obvious to most people that diabetic patients cost more, they have longer length of stays, more problems, more procedures, more complications. So actually, some of you might remember Carlos Estrada, who was in general medicine here a few years back, and he worked with our heart surgeons and showed that at Pitt County, as we called it at the time, every 50 milligram increase in glucose added about 3/4 a day length of stay and increased cost by about $3,000. In contradistinction, every 50 milligram lowering of the 3-day post-op average reduced length of stay. And Fenari in Portland, a bigger study, showed basically about the same thing. So I mentioned before about the Leuven data, where they were looking at very tight glucose values in the 110-140 range. And that study was not actually been able to be replicated. And one study called the Nice Sugar Study said that really, in fact, when you got that low, there was more problems. This quote reminds me of the statin trials when you have everybody getting treated and it's hard to see a delta between the two groups. But basically, in their control group, the mean glucose was 144. And we would think that's really, really good. And the other group is 118, and that one had a 6.8% rate of severe hypoglycemia versus 0.5 in the other one. And this has led to kind of a pullback now, so that the main targets for most of the patients have been 140 to 180. They're still using a lower target. Again, the weak link in the chain here is having really accurate real-time glucose measuring. And when that's done, I think we won't have to worry so much about some of these targets. So this is in response to the Nice Sugar, Dr. Vandenberg looked at her data. So here's the patients who are above renal threshold here versus those in the normal range, and this is why she showed a definite improvement in mortality. But then, and then here's the nice sugar. So they were actually pretty good. But the thing of it is, you've got this little tail here of the J curve that starts coming back up at the end. And this is some of the organizations, what they say. I don't have the ACP on here, but the ACP says blood sugars under 200. I kind of think that's too high. I disagree with it. ACE groups, ADA, and also Society of Hospital Medicine are looking for less than 180. And that's basically what the levels we are looking here. So for IV insulin, 140 to 180. For sub-Q, 70 to 180. And there's some places like L&D, for example, you need tighter targets. So many patients today with type 2 diabetes are treated with oral agents, sulfonylureas, metformin, and some of the newer agents, like sitagliptin, for example. And really the evidence that you should stop the medication, unless maybe they're on psych or rehab and they're perfectly stable. Patients sick enough to be in the hospital, even say for example, they have pneumonia and their blood sugar, A1C might have been 7 on oral agents, but now their blood sugar is high. I mean, there's no point giving these drugs. They're not going to be effective enough. And sometimes, if the patient's not eating, they can actually be dangerous. Sulfonylureas in particular are dangerous. Endocrinologists are trying to lead the charge away from these drugs. Metformin you can't give in people with renal condition. TZDs cause fluid retention, and the GLP-1 agonists and DP4 inhibitors haven't. There's some suggestion that DP4 inhibitors may be useful, but I think there's really not good data on that. Society of Hospital Medicine says to hold it. ADA says to hold it. So that's basically the overall emphasis now is not to give it. And why are we going to give insulin? Because insulin is the drug of choice. It's the most potent agent we have. It really is it's life-saving, it's essential, but it also can be technically very dangerous. So here's what was written in 2006, and you can see here that patients, oral agents, I made that red, you don't use. Insulin is recommended here. And then here is IV to sub-Q, and we'll talk about each one of these. So what about IV insulin? These are the indications for IV insulin: diabetic ketoacidosis, hyperosmolar state, critical illness, NPO type 1 patients, L&D. And sometimes patients have 300 blood sugars and you can't get them resolved. You could get them in, tune them up with IV, and then you could switch them over to sub-Q. All right. So there's two ways of giving IV. The most commonly used is the paper protocol, but more recently has been EndoTool. So EndoTool was actually a program that was written by Pat Burgess, a nephrologist in Charlotte, and who had a math background, I guess, and he was trying to improve glycemic control and reduce acute renal failure. And he utilized 33 algorithms, and the system has about 12 negative feedback, downregulation, and 6 positive. The idea is there's more algorithms to prevent hypoglycemia than there are to reduce hyperglycemia. We had the glucomander for about 5 years, and then since February of 2009, we've had EndoTool, and we've increased the number of units that has it. And in fact, EndoTool is on almost all the units today, except I think 2 South, 3 South, maybe one other. So the key point is that you have a decreased incidence of hypoglycemia with this when you use the EndoTool. Here we go. So here are the units that all the ICUs, MIUs. So the only units that do not have it are 2 South, 2 East, 3 South, and the ED. So in those units, if the patient needs IV insulin, you'll have to transfer the patient. So this is some data we collected. I presented at a poster at the ADA in Chicago last year. This is data over 5 years, 8,000 patients, 260,000 values. So this is the incidence of hypoglycemia here. And this is the 15 minutes means a nurse did what she was supposed to do within 15 minutes. When those little San Francisco gongs go off, that means, okay, it's time for her now to do a blood sugar and adjust the setting. But if she doesn't do that in a while, it's not as accurate. So they do it with an accuracy of 15 minutes. You see the overall incidence of under 70 is 0.86 and less than 40, 0.02. That's, only represents 61 values out of 260,000. There's no way anybody's going to do better than that. As far as I know. So when you transition patients you have to make sure that they're eating, and they should ideally be off pressors or the inotropes. If they're on steroids, the steroid dose should be stable. And then they should be, if they're on tube feed or TPN, that should also be stable. And so then when you transition them, you're going to then put them on sub-Q insulin and do the finger stick blood sugars every 6 hours or with meals if they're eating. The most important thing you need to know is that the half-life of IV insulin is 5 minutes. So if you turn off an insulin drip, within 15 minutes or so, there's no insulin. So in a type 1 diabetic or many type 2 patients, you're basically going to have hyperglycemia. So if you're going to give a basal insulin or even short-acting insulin, always turn that off. Always give that dose, and then don't turn off the infusion for at least 2 hours, because it takes a while for that sub-Q insulin to build up a depot in the system. And that's why you need to wait that period of time. So we have basal insulin for heightened metabolic requirements, prandial insulin for covering food, and then correctional insulin. So this is a sort of a typical total daily dose of insulin that's sort of recommended. This causes both basal and for bolus. And you see, to some extent, it's going to be based on whether you have type 1 or type 2 diabetes and your GFR. So the basal insulin concept is the amount of insulin required when food is not absorbed, so basically on a fasting state. So a type 1 diabetic takes basal insulin once a day and doesn't eat, their blood sugar should be perfectly fine. And that's basically the story. But if they don't have it, what happens is they become ketotic, and of course hepatic glycolysis is no longer suppressed, and you have increased glucose from the liver. And basal insulin in general is about 50% of daily needs, but it's probably going to be more in the hospitalized patient. You're all familiar with the basal insulins. The one that's on our formulary now here is Glargine insulin. NPH can be used, but it's much more dangerous in that respect and it has more hypoglycemic issues. So we like to use weight-based dosing. We think the weight-based dosing is the best, and we highly recommend that you use weight-based dosing as opposed to calculating it from IV. So this would be the starting doses of Glargine, again, based on renal function, based on age, because older people, which of course have worse renal function, and very thin people are going to need less. So a caveat is that patients who are sick, are hyperglycemic, have stress. As that resolves, requirement comes down. And if you don't sync these together, what will happen is you will have you'll have hypoglycemia. And if you transition too early, you'll lead to loss of glucose control. So this is representing, this is kind of the holy grail of diabetes. This represents insulin in a person who's eating, who's normal. And this would be the basal over here, and this would be the mealtime. And then if you go ahead and you just gave a basal insulin, that's fine. But then what happens is if you try to raise a dose to regulate it, you'll see you'll have too much insulin over here, and you certainly still won't be able to manage the food. So basal insulin here, and then the other one with meals we just call bolus. So the bolus insulin is to limit the hyperglycemia after meals, and basically it's going to help keep the patient controlled. And this can be 50%, or it might be somewhat less in the hospitalized patient. There are some differences between the basal, for example, between insulin Taneberg and insulin Glargine, but there's almost really no difference between the fast-acting analogs. And we prefer the fast-acting analogs that people are eating because you can give them with the meal, and if they're eating erratically, you can actually give them right after the meal. The study shows you can give these insulins after the meal, and it works very well. And we do something called graduating dosing. So let's say you decide your mealtime dose is going to be 6 units. So for these people, you might just give 3 units if they only eat half the meal. And that's because you can do it, give it right after the meal. It's been shown to work. Where you can't do that with regular insulin, you'll get much more trouble with hypoglycemia. So so in our hospital for finger stick blood sugars, we have Lispro insulin, and you give about 1/3 with each meal. If the patient's NPO or on tube feeds or TPN, you would then give about, you can use regular insulin every 6 hours. So if you gave regular NPH insulin, which is sort of what we do with people that go to Walmart, they have no money, no insurance, you can do okay, but you see you still don't really simulate the normal physiology very well. If you use the analog insulin, which costs a lot more money, you can see you do a much better job. So this is from Dr. Braithwaite showing that basically we have a basal insulin here, and you're going to have insulin with meals or supplemental stress, or we call correctional insulin. So the components of the basal insulin I've already mentioned, and I talked about nutritional insulin. If you have a patient on TPN and you put insulin in the bag, it's very effective because what happens then is if the TPN stops, the insulin stops. So that, in fact, is very, very effective way to do it. Giving IV insulin, again, is good, but it's going to, of course, require more fingerstick testing. And then we give insulin first. We're trying to use the word correctional rather than supplemental insulin. And then that's going to take care of meals as well. It's going to take care of blood sugars that are high from maybe meals or from steroids or stress. And again, remember, this is going to decrease as the patient improves. That's why you need to look at the blood sugars on a regular basis. So if you look at these components, the basal really doesn't change too much, whereas the prandial actually is going to be higher, especially if they're on tube feeds or TPN. And then stress dose, insulin for stress is going to be much, much greater in stress and correction. So now we're going to go, we've talked about IV, let's going to talk to sub-Q, and which one are we going to use for sub-Q insulin. So in patients that are hospitalized, you know there's an ADA algorithm, you start with metformin, forget that. Start insulin. And the way you use insulin we're going to talk about is you can use IV or sub-Q, you're not going to use sliding scales. There's a friend of mine named Paul Davidson who's in Atlanta. Used to be a professor at West Virginia, and he just was a pretty smart guy. And it was known that a typical 70-kilogram person taking 50 units a day of insulin, 1 unit of insulin would drop the glucose about 30 milligrams. He said, well, that's interesting. I wonder if a person's taking 30 units, if one would drop at 50. And he kind of played with this for a while, and he came out with this thing called the 1500 rule, which was basically like a constant, like pi, to see if in fact, could you develop an insulin sensitivity factor. So, for example, here, if you're taking 50 units a day, 1 unit drops your blood sugar 30. If you're taking 10 units, though, 1 unit drops it 150, and if you're taking 250 units, 1 drops 6 units. So basically, you're giving insulin in relation to how sensitive the patient is. And the sensitivity is based on their weight or possibly the amount of stress they're under. So he called this the insulin sensitivity factor. And he did it in his clinical practice, and our book we wrote on the insulin pump, he published a chapter on that. But they did more scientific stuff, backed it up, and they found with the analog insulin, 1700 was a little better than the 1500. But 1500s work very well, and we have the 1500 thing set into the computer so you can actually access that here at the hospital when you do sensitivity factors. So correctional insulin is an adjunct to scheduled insulin. The supplemental correctional is going to be short-acting, and the point is, if you put patients on correction only and you're keeping to make a lot of changes, you need to go back and look and see maybe the patient needs more basal insulin or needs some more prandial insulin. So here's the formula if you want to do a correction. So sensitivity factor would be 1500 divided by the daily dose of insulin. If you don't know what much they're on, we usually estimate taking the daily dose of 0.5 times the weight in kilograms. So correctional equals current blood sugar minus target over insulin sensitivity factor. So if it's 1500 rule divided by this weight, it turns out patients requiring 50 units. 1 unit drops to 30. Therefore, every unit will drop it by about 30 milligrams. Another example, say, this is made round numbers to make it easy. 250 blood sugar, targets 100, sensitivity factor is 30, and you actually end up getting we get 5 units for that. If you have a patient whose blood sugar is 190 and you want to get to 110 and your sensitivity factor is 40, that would come down to giving 2 units. And you always round the numbers down to nearest whole number. So this is a little old, but I want to show it just for those who are new to talk about why we don't like sliding scales. This was 2 patients that we had before. One patient had a blood sugar of 265 and was requiring IV insulin 192 units a day. One patient had a blood sugar of 412 requiring sub-Q 17 units a day. So this is, you've seen these old sliding scales. I hope I never see one again. But this is what has been in doctor passed down from house officer to medical student to house officer for like the last 30 years. It used to be on urine testing, believe it or not. So here's your patient, and this guy's a big guy, and he's resistant, and he's getting basically 8 units an hour. It's 192 units. His blood sugar is 265. So if we use our calculation and we divide this 192 to 1500, that would say that 1 unit should drop his glucose about 8 milligrams per deciliter. And if we make the target 100, what's going to happen? You'll see that basically at the sliding scale, say give 4 units. So 4 times about 32 should drop down, which isn't going to really do anything. Kind of like peeing in the ocean here. But if you do the calculation based on this sensitivity factor, he needs about 20 units of insulin to get his glucose down. And that's what happened to these big people, is they end up, nothing happens to them. That's not good. This is worse. Here's a patient who's using very sensitive, skinny person, using Glargine and maybe Licepro at home, total dose of 17 units. He's in the hospital, blood sugar is 412, and the sliding scale says, well, for 400, you got to give 10 units. Well, I don't know about that, right? Because if each unit, if you look at this calculation, his sensitivity factor is 88. So if each unit is 88, 88 times 10 is 880. That's your negative numbers here. He really needs about 3 units. And this actually was a true story, real case. Patient received 10 units, had a seizure. The next glucose after 2 amps of D50 was only 14. So thin patients, sensitive patients, really need a lot less insulin. And renal patients as well need a lot less insulin. And the studies show that people who have CKD without diabetes are more prone to hypoglycemia. If they have CKD and diabetes, that's much more concern. So CKD, older patients, very thin patients are going to need a lot less. So, quote, the traditional sliding scale consisting of regular without intermediate or long-acting has been shown to be ineffective at best and dangerous at worst. Okay, so how do you order insulin? This is a advertisement. You use the order set. Because you use the order set, and you go to order set rather and you just type insulin, you get all the order sets and you plug that in, add it to your favorite, and what will happen is then everything's happened. That allows the nurse to follow the hypoglycemic protocol and not call you to have to give D50. It basically, it puts in place everything you need to protect that patient and do it more efficient. And it's easier. So I urge you all to use the order set, and it's very simple. Keep in mind that the order sets that we have are for non-pregnant adults and not for children. There is a DK order set, but keep in mind with a DK order set, you also have to add an insulin, because the DK order set only gives you fluid, electrolytes, labs, and so forth. So you have to add the EndoTool order set as well for DK, and the new version of EndoTool will have a special separate, we're getting a new version soon. It's going to have a separate DKA set, and it's also going to have a pediatric set too. If it wasn't for hypoglycemia, any medical student could treat diabetes. This is the problem. This is the one thing that makes it very, very difficult for us to treat people with diabetes, because our most potent drug has a very serious side effect. So in my 35 years or plus of managing diabetic patients, I've had 4 people die of hypoglycemia. I've had several hundred die of diabetic complications. So the question is, how can you balance treating patients so you don't get hypoglycemia? Because you need the insulin in patients that are sick, and patients, of course, that require insulin. And so the number of hypoglycemic events in the hospital is very significant. And so the mortality is higher. So, for example, people with hypoglycemia have mortality 20% versus 4.5%. People in the ICU, 62% versus 29%. But there's another situation. That is the fact you have spontaneous hypoglycemia as well. People are not given insulin. This is not iatrogenic. It's a different story. Spontaneous hypoglycemia is different than iatrogenic. Spontaneous hypoglycemia is probably a marker, if you will, of the patient's state. And so when you have spontaneous hypoglycemia, actually studies show that the mortality is actually greater than people that have iatrogenic hypoglycemia. If you have spontaneous hypoglycemia, that's really when you have to get an endocrine consult and see what's going on. And I will say we get a lot of these consults. The most common ones we see are actually not spontaneous, because maybe the patient was on a sulfonylurea before they get in the hospital, or the patient was taking this medicine we didn't know about. But then after that, the next most common one is for people with end-stage renal disease. Because in end-stage renal disease, not only you have insulin circulating much longer, but you don't have the glycogen in the kidney, which helps protect you from hypoglycemia. And then if they're not eating, you have the glycogen in the liver. So basically, that patient is defenseless against insulin. That's a really serious problem. All right. So many studies have been done at the most common cause of hypoglycemia. And we did our own study here, and the number one cause was the dose was too much. So how do we fix that? By teaching everyone how to use weight and GFR-based ordering. Another problem is the CKD, and that requires some special things to do for those patients. It basically give a lot less insulin. And also in CKD, if they're on dialysis, particularly if they're on peritoneal, that could be a real issue there. Deal with the tube feeds. And when people have steroids or being tapered, you have to make sure everybody knows about it. So I think studies show that one of the biggest problems leading to these things is lack of communication between the doctors doing the insulin and the doctor ordering the tube feed, for example, or the TPN. Or the nurse doesn't tell the patient, well, this patient's been given sub-Q insulin and they just pulled their tube out, or whatever. So there's no communication between the two, and that's a real problem. So many of these things can be fixed. They're not impossible to fix. And there's also medication errors. We had a traveling nurse here 2 years ago who, when she thought U100 meant to give 100 units. I don't want to tell you about that one. So hopefully we can avoid those kind of errors. So here's a study we did our hospital. Dr. Hardy put together this information. So from 2012, about 6 months, to May 2013, we had about 400 cases of glucose less than 50. So 47% excessive dose, 43% renal impairment, decreased nutrition 31%, given the home dose, which we don't recommend, 22%, on infusion, sub-Q transition, sulfonylureas, premix, should never use that in the hospital, tapering steroids. Now this is, to me, the most egregious. Patient was hypoglycemic within the previous 24 hours. So if a patient's hypoglycemic on Monday, if you don't change the insulin and they get hypoglycemia on Tuesday, shame on you. So regimen just by provider, sometimes after a call. So that in that 6-month period, we had 2 events of harm, 1 a seizure, and 1 a patient with a severe arrhythmia, PEA. Oh, here's a slide about the renal disease. This is from a nephrology journal. So this is people who have CKD and no diabetes. And you see here's glucose less than 70, under 60, and under 50. And you see it's really, these are non-diabetic, non-renal disease. Now just look at renal disease only. The CKD, and I'm not sure exactly what the average creatinine was, but you see there is about a 50% increase in hypoglycemia of CKD alone. A little bit, hazard ratio. It's actually a rate ratio. So then if you have diabetes but no CKD, of course you have a lot more. But look what happens if you have renal disease and diabetes getting insulin. This one here is under 50. Glucose is less than 50. That's why we have to be so careful in people with renal disease when you give them insulin. And you have to dose it appropriately with weight-based dosing. So another thing is you've got to monitor the blood sugar. So, here's the doc flow sheet. You've got to get on there and you've got to look at the blood sugars every day and see. Now, so their blood sugars, if they're running lower, consistently below 100 or above 180, you have to reassess the regimen. And if it's less than 70, you need to do it right away. So you have to be monitoring this thing because you're responsible for this patient. We're all responsible for the patient. So I'm not going to go over a whole thing on treatment. Basically, we have what we call the rule 15. On the outpatient, you give them 15 grams, wait 15 minutes, and then another dose. In the inpatient scenario, if they're on the hypoglycemic protocol, the nurse will give either an amp or half an amp of D50. So that's why when you use the order set, they get that. They can do that for you. So if the patient didn't have a line, for example, they could use glucagon, but in my experience, we don't use too much glucagon in the hospital. They can usually find a way to get IV access. It's more important prevention. How do we prevent hypoglycemia? Well, I already said, use the order set. Do not use sliding scales. We try to avoid NPH insulin in the hospital setting. Use analogs. We're here, they're spending millions of dollars on other stuff. You can spend a few extra bucks and give them the good insulin and get them better control. And address the predisposing conditions, what we just talked about. So we think it's we have a called Diabetes Best Practice Steering Committee. Dr. Hardy and myself sit on with Dr. Garrison, And our goal for this year was to reduce hypoglycemia in this hospital. So one of the things we've done is set up a quality snapshot. Another thing is we give a report on a monthly basis to the unit manager, unit medical directors, and managers of each nursing station, each service line. We've also set up a hypoglycemic task force, which is co-chaired by Dr. Shiv Patel. Are you here, Shiv? You want to raise your hand? He's on the back over there. He's one of our diabetes fellows, and he is and another individual are heading a task force for hypoglycemia to try to basically identify where the problem is and how to reduce this thing. And so you've heard about CAUTIs and CLAPSIs and all that stuff. Sooner or later, hypoglycemia and diabetic issues are going to make it to that thing from the feds, may be passed down, I think. So we're trying to be ahead of the game. We're trying to help our patients and follow good clinical practices. And that's why we have a hypoglycemic task force. So what about education and discharge planning? As some of you may know, we don't have the nurses like we used to have, so and so instead we've come up with a new program, and this entire plan was actually Dr. Sandra Hardy came up with this program, and I give her a lot of credit, and we're trying to get buy-in. So basically what's going to happen is the bedside nurse is going to know how to get the patient, teach them how to use insulin, how to do finger stick testing, what to do with hypoglycemia, and who to call. Just basic survival skills. The pharmacist will be involved if the patient is on a pump, U500, has any learning barriers. For example, they can't see a syringe, have alternate medications. Then the nutritionist is going to be involved and look at these patients from a nutritional point of view and make sure that they're getting the proper nutrition. The case manager is going to be involved to make sure that the majority of the education will be done as an outpatient basis. And we have community places in home health that will do that for you. And so then basically they have toolboxes they can use with resources to help them with education. So what we have basically is a safe and effective management program, order sets, daily monitoring, discharge instructions, and follow-up with the diabetes provider. So this is what we try to do for non-pregnant adults, and we're trying to assess to see how this works. I mentioned before about the A1C. So this is from Diabetes Care in 2008. And basically what they say is if you look at the A1C when they came in, if they're known diabetic, you might want to step up their therapy. So you might need more shots, add basal here, multiple injections here. So you might want to take, so I think this is helpful to plan for discharge and going home to see what they might want to do. Because if the patient comes in at A1C 10 and 11% and they've been supposed to be treated for diabetes, obviously that's inadequate treatment. If they're coming in for pneumonia, it's very possible that hyperglycemia was an important contributing factor in that pneumonia. I had a different deck that had the actual order set, but there is an order set for diabetes discharge supplies. And you just click on that, and when you do that, it prints out the prescriptions for the strips, meter, lancets, pen needles, syringes, whatever they need. So there is on the order set a discharge order set. So many of you remember the little blue book. It's been going around for about 10 years. Sort of blue anyway. We used to pass them out to all the house staff to put in their pocket. So we decided, they've decided to go green. So you have to now download this to your smartphone or device or so forth. So if you go on the home page, here it is, right here. You really lit this something up for me, didn't you? Here. All right. You go on the home page, you can download this. Now you're going to put them to sleep. Where's my chief resident here? No. All right. I think people lean on that light switch all the time. There we go.
You can keep going on.
All right. So anyway, I mentioned that. So this is the blue book. Now illegible. Okay, there we go. So in the blue book are things that are very helpful you need to look at. It's now up to about 35 pages. So one of the most important things is it's not just our hospital, but Vidant Health principles and standards of how to manage diabetes. And then it has things like IV, sub-Q, DK, all things I've been talking about, pattern management, when to consult, a list of the order sets, profiles, hypoglycemia, steroids, kidney disease, U500 pumps. And then there's some actually case scenarios that are very helpful to use. And you go through these, I think this will be helpful. I hope all the house staff downloads this and look at it, or just look at it on your smartphone or your tablet. So I'm running early, so I'm going to, I've been known to be humorous. I'm going to show you something humorous. If you're a nurse, please don't be offended. I got to make this is going to lead into the weekend. You can all go out and have some beer after this. So I hope this works.
Doctor, come quick.
Yes, nurse, what is it?
Are you covering the red team?
No.
Are you the trauma intern?
No.
Are you covering blue team 4?
Yes.
Good. I have been looking for you all night. Do you have the patient in room 27?
Bed A or bed B?
Hold on. Bed B.
Do you mean Mr. Black?
Hold on. Yes, Mr. Black. Doctor, his finger stick is 155.
Okay, thank you for telling me that.
Doctor, the patient is ordered for insulin.
Good.
Doctor, should I still give the insulin?
Yes, that is why it is ordered.
But doctor, the finger stick is 155.
I know. You already said that.
The patient is ordered for Lantus 24 units.
Good.
Doctor, don't you think that is too much?
No. The dose is calculated based on his weight, his hemoglobin A1C, his comorbidities, his level of insulin resistance, and has been titrated based on his response to insulin over the past 5 days of admission.
Doctor, the patient may become hypoglycemic.
Nurse, give the insulin.
Doctor, maybe we should push D50.
Nurse, insulin Lantus lasts for 24 hours. It does not have an onset for 4 hours. It does not peak. It is a basal insulin. It would be the equivalent of giving the patient 1 unit of regular insulin per hour for 24 hours. It counters the body's natural gluconeogenesis. The patient will not become hypoglycemic.
So do you want me to pull up the D50? I'm not allowed to push it though. You must push it yourself.
Nurse, give the insulin. Without it, he will be hyperglycemic for the next 24 hours. Last night he got Lantus 24 units and his morning finger stick was 120.
Oh my God. Did they push D50?
No.
Did they give the patient orange juice?
No.
Did they call a code?
Nurse, give the patient his damn medicine right now.
Is it okay if I also give him orange juice? Doctor, where are you going?
To blow my brains out with a shotgun.
Okay, I'll pull up the D50.
That resident's pretty good. He understood what I'm trying to tell you. I don't think anyone, our nurse in this hospital is as bad as that one, but I felt it was.
I have a comment. When you say we don't have nurses like we used to, you were referring to the fact that we've lost our
Educator nurses. Right, yes.
And our nurses that are currently present.
No, right, no. Yeah, that's what I was referring to. So I think I have a lot of time for questions. Yes, Dr. Bowen.
Bob, if you were to take, pretend you had all the IT resources that you needed, and you were to take every inpatient blood sugar drawn in this hospital in the past 5 years and dump it into a computer program and regress that line out, what would that look like? Would the standard errors be coming in? Would it be falling? What's your gestalt for that?
Well, we know that the people on IV insulin do a lot better. There's no question. I mean, really. I mean, when you give someone sub-Q insulin, the train's left the station. So you gave them Glargine, you gave them NPH, regular, whatever, and now the tube feeds out. I mean, those things are going to be a problem. So we have tried. I think, we are a lot farther along than we were 10 years ago. 10, 12 years ago, we still had sliding scale usage. We had a lot of NPH usage. We actually outlawed 70-30, but someone snuck it back on the formulary. So I think we really are ahead of most hospitals in the country, especially large teaching hospitals, in getting things down, trying to use this format. So really, right now, working at the more, the fine tuning, and when we find that, for example, the nephrology patients have a lot more hypoglycemia, that's a low-hanging fruit we can do something about. Then we have, actually the surgeons have bought in usually pretty well. Not just the cardiac surgeons, but some of the other surgeons have bought in pretty well. I know transplant surgery, bariatric surgery, they all want better control. OBs have bought into this for many, many years. There's been a few outliers. We had to convince orthopedics and some of the other urology areas. So what the problem is, you have many people involved. You have a physician or an extender who's writing the insulin orders, or using, hopefully, the order set. You have the nurse who's giving it. And then you have the various patients they're dealing with. So if you want to, you have to educate the provider to do it properly. And I find, personally, my biggest challenge are some of the hospitalists who trained elsewhere. They came from somewhere else where they're still using sliding scales. You don't understand. You don't understand the physiology of diabetes. You can't really treat the patient properly. And the other problem, big problem, is people are concentrating why they're here. They're here for pneumonia. That's the big thing. They're here because of MI. It's that thing. So the diabetes becomes a side issue, but many times it's not a side issue. And that's the problem. So they're all focusing on the main reason for remission. So we almost never admit people for diabetes as a primary diagnosis, unless it's DKA, for example, hyperosmolar state. But most of the time they're being admitted for something else. And I think the focus of the provider is on that something else. And so I think we have, again, I think we're better than probably 80% of the hospitals. Now that data I showed you, that the hypoglycemic data, and we look at all the surgical data, and we are in about the top 10% in terms of surgical data in the country. We do very, very well. We're working on that. And I think part of it is that because we agreed to continue Endo 2. Endo 2 cost the hospital about $200,000, but they agreed to continue paying for it. So now some people say, well, the residents will not learn how to use insulin because they won't have where they're going to go. They don't have a paper protocol. Well, sorry, you know. You know, it's like in the old days, your house by MRI, the other place didn't, and so then you should go somewhere. Not, you know, the point of the matter is this is an advance in medicine. I mean, and computers are better than people. Glucose is a trajectory. It's like a vector in physics. It's always moving at a speed and a rate. And if you can calculate how it's moving, and in the outpatient setting, we have real-time sensors that patients wear that shows at blood sugar at any time, and it shows the trend and how it's going. And people on that do much better than people just pricking their finger 4 times a day. And by the way, they are trying to get these sensors, which measure interstitial glucose, into the hospital setting. That's going to happen sooner or later. Because that is the weak link. That's why, if it wasn't for that, none of these protocols would be a problem. Because you could get better control, tighter control, without the worry of hypoglycemia. Now, one thing I'll just say is we have a new meter now. If you notice, we have all new meters. Now, these meters are much better. They're much more accurate than the other one. That's the most important, be more accurate. And it requires less blood, so it's less painful to the patient. And also, the blood sugar, the blood sugar data is automatically transmitted through wireless to the medical record. So the nurse doesn't have to head into it. So I think the new meters will help. So did you have a comment?
It was a huge. I was going to compliment you on getting that on board. That's been a huge advance, I think, as far as just practicality for the patients and for the nurses.
Yes.
So periodically we get on the neurology service, and actually last weekend we had a person with an episode of severe hypoglycemia that's transferred in with an encephalopathy.
Yeah.
And the question is, was it a hypoxic ischemic encephalopathy? Did they have a stroke? They might have had a seizure, and then we try to sort out if they're in non-convulsive status epilepticus. But now you've helped me to identify some people who are more at risk for hypoglycemic
stroke patients. Stroke patients already have oxygen deprivation in their brain. You don't want glucose deprivation as well.
But these aren't stroke patients.
But these are just from hypoglycemia.
Right. And so, but one of the things I have difficulty with is identifying what their prognosis is. Like how long to wait for their recovery, and is there any data on how you can project their?
There have been people on hypoglycemic who became comatose with hypoglycemic and are vegetative for years. There are cases of that, absolutely. Lawsuits too. In fact, it happens in the hospital. Patient gets hypoglycemic, get a common brain damage, never wake up. That's like a $1 gazillion loss. So I mean, that absolutely. Fortunately now, in kids, the younger people may do better because the brain is more, regenerate and plasticity. And I think younger kids, I've seen young kids who've been hypoglycemic and took like 2 or 3 days to recover. They come out fine. One of the things that was always a concern back in the 70s was, are we causing brain damage to young people? And the pediatric endocrinologists were scared to death of hypoglycemia. You still are, which is okay. But at least they showed in DCT they did not cause it. These were all type 1s as young as 13, did not cause loss of intelligence or brain damage. And I think to really get brain damage, you have to have a very hypoglycemic for a long time. Now, that being said, if your glucose gets down to 10, 20, you can die from coma. You will die. And that's the one case we published. This case, we had a young man who is a type 1, he was on a pump, and was kind of pushing the envelope, trying to make himself do the A1C down. And we put on one of these sensors, but in those days the sensors were not real time, it was like a Holter monitor. He had come in through emergency 2 weeks before. His parents found him, he was 23, found him in bed, hypoglycemic, and he revived. So we came back to, so he adjusted his pump, and I told him he put this on. So we put this on Friday, and Saturday morning, he's dead in bed, like 2 weeks later. But what happened is he had worn the sensor, and the sensor showed that he was going to the gym, and he took a lot of extra insulin in the evening, ate, took some more insulin, and then his blood sugar basically went from like 180 all the way down, and actually went down to a level of about 10, and he died. And that actually was the first time anyone ever documented the dead bed syndrome, so-called dead bed syndrome, was really due to hypoglycemia. And that, I'm very proud of that because I got rejected by 3 journals. I finally got one to publish it. And that particular case was helpful to the Juvenile Diabetes Research Foundation to get NIH. It was actually, that slide was used to get NIH to help fund work on the artificial pancreas. And again, because of the concern we have with kids hypoglycemia. So the little sidelight is, if you get rejected, apply somewhere else. If you believe in what your case, or you think your case is important, you really need to apply to another journal. Someone's going to like it. A lot of people reject it the first time. Is there another question back there? Yeah.
I was actually wondering with EndoTool, I know it's slightly different for your CKD patients versus your non-CKD patients. Do we have, or is there some way I can adjust it for end-stage renal disease? Because I've had a couple of incidences where they come in, I put them on EndoTool, and then the next morning I'm chasing hypoglycemia for a few hours.
Where's Dr. Hardy? Is she here? Do you have any suggestions about that?
What I think might be happening sometimes is that EndoTool requires some administration of dextrose along with a small amount. So I'd ask first, was there some D5 running to avoid that hypoglycemia? The second thing I was worried about is if it had a patient who was receiving some supplement before admission. And if so, that might, especially in a CKD patient, is going to be prolonged. And the recommendations are to reduce the endocrine doses. So if we did both of those things and still had hypoglycemia, I'm not sure why that.
So I mentioned before how about end-stage renal disease. You've got no glycogen in your kidney. It's an important source of glycogen, so that's not there. The insulin lasts a long time that you give, and also the nutrition. And the worst hypoglycemic consoles we get are for people that have CKD who are not eating, or alcoholic, or have liver disease. Did you have a comment on that, Paul?
Yeah, I would just add to that when you dialyze somebody, you dialyze them against the bath and blood sugar 132. And you don't know what occurred prior to that episode of dialysis fixed, that therefore you don't see it after. So that occurs on an episodic basis in these patients, and I have no idea how much glucose is actually transported. But there's a fair amount of glucose in the dialysis.
There are papers showing that people on dialysis days and non-dialysis days, there's a difference. There is clearly a difference in their insulin requirement.
And on PD, of course, we use glucose to affect the transport.
Yeah, and PD, when they use a higher concentration of glucose, it's always a problem. So we have to sometimes add NPH just to cover that when you go to bed at night. It's very problem. It's very difficult. It's not easy stuff. Definitely not easy stuff.
So the dialysis bath is about
132 last time I checked. I don't do a lot of dialysis these days, but it might be a sensitivity issue on non-dialysis days, and you just want to keep that in your head because you're getting a little extra meal on that day.
Other questions? Okay, thank you.